Hi, everyone. Let's get started. Thank you for joining us today for this is our fifth webinar of this year, expanding access to opioid use disorder treatment during and after incarceration. So to get started, I want to get right into this because we have a lot to talk about today. My name is Ken Chaskis. I am the program director here at the Foundation for Opioid Response Efforts. Just a quick overview of the agenda today. I'm just going to be going over a little bit of an introduction as well as webinar logistics. You will then hear from three of our grantees on a number of issues surrounding the 1115 waiver. At the end, we'll have about 25 minutes or so for an audience Q&A. That'll be moderated by our president, Karen Scott. Quickly, if you haven't been to a FORE webinar before, all of the webinars are recorded and it will be available shortly on our website, forefdn.org, after the session ends. The slides will also be made available for download on our website. Please use the Q&A found at the bottom of your Zoom screen to ask any questions. We will get to as many as we can at the end of the webinar. But to make sure that we're going over the ones that are the most, that people find the most interesting, please upvote using the thumbs up button on the question so we're getting to those ones. We'll get to as many as we can. If there's a lot of them that we can't get to, we'll do our best to make a frequently asked questions and FAQ that we can publish on our website. Finally, we love to hear from you and how to be able to improve these webinars. So there'll be a brief survey immediately following the webinar. Please provide us with that feedback. Quickly, FORE's grantee portfolio, we're now at 74 grants to date and 33.9 million awarded. You can see all of our grants on our website and all the projects as well. Quickly, just a brief overview of FORE's programs and partnerships. We have a number of grant-making programs that are focused on a number of emerging areas to date. One, our very first program was on access to treatment for vulnerable populations, which the three grantees today you will hear from, that was part of that program. We then pivoted during the COVID-19 pandemic to trying to understand the evaluation of regulatory policies that were occurring during COVID, as well as supporting recovery services and those in recovery during the pandemic. We held an innovation challenge to tackle some of the opioid crises' most intractable problems, such as stigma, as well as generating more timely and actionable data. We've also have a family and community-based prevention program looking at more upstream interventions for children and families at high risk of opioid use disorder and overdose. Coming soon, which I know many of you are waiting for, we will be also announcing the awards to our latest RFP that were focused on supporting community-driven responses to opioid use disorder and overdose mortality. Before I jump into the webinar on this issue, just want to alert all of you that we did publish an issue brief today on this exact topic that goes over as well the four grantees that will be presenting today. I believe that will be put in the chat throughout the webinar, so you can take a look at that. We'll also blast it out to everybody so that they have a copy, but feel free to go on our website and take a look at it. With that, I want to jump right into our presentations today. We have a fantastic lineup of grantees, as you can see listed here. And we'll just jump right into our first presenter, Gabrielle de la Gueriniere, who is the Vice President of Health and Justice Policy at Legal Action Center, who we've been advocating for a long time for this 1115 waiver and changes to it. So really happy that she's able to make it. Gab, take it away.
Great, thanks so much. I really appreciate FORE Foundation convening all of us and appreciate all of you for participating today, because we have some really exciting, hopeful things to talk about, which is nice. So today, leveraging Medicaid's new reentry demonstration opportunity to improve access to opioid use disorder and other needed care before reentry. Next slide, please. And if you don't know about Legal Action Center, you can Google us, or my contact information is at the end too. So what I'll talk a little bit about today, because I know we have a bunch of us and lots to talk about, give a little background about Medicaid reentry, about kind of leading up to approval of California's 1115 waiver, the first of its kind. I'll then provide some highlights of the key provisions of the waiver so we can kind of understand the world we're potentially working in. And then throughout, I'll talk a little bit about next steps, challenges, opportunities, things that we're anticipating in a bunch of directions. And I'm looking forward to the question and answers at the end. So next slide, please. And next one more. Okay, so as we all know, just to ground us a little, and again, know that folks are extremely aware that many people who are incarcerated have significant untreated health conditions, and that many people have untreated substance use disorders, including opioid use disorders and mental health conditions, in addition to a whole host of other physical health conditions because of lack of care, lack of coverage in the community. We know too that access to care during incarceration is extremely limited. And we know that there are a number of reasons for that, but two I'll mention are stigma and discrimination and financing barriers, particularly around Medicaid, which we'll talk more about. Then as people are coming home, we know people, again, often face disruptions in coverage, which means disruption in care, and that around the country, there's been a patchwork of work related to Medicaid coverage, at reentry, suspension policies, that some that are helpful, some that are not, termination policies that remove people, and again, make it very difficult for people to access care as they're coming home. And then we have to acknowledge racism systemically in all of our systems, but we'll mention here the criminal legal system and the healthcare system, meaning that Black and Brown people are overrepresented at arrest, harsher sentencing, at incarceration, and at reentry face a number of different barriers that make it very difficult. So we, again, when we talk about health equity, this is a huge problem, knowing what we do through our criminal legal system policies. And then we know when people come home, they're extremely vulnerable to overdose, to suicide, and they often are sicker than when they first were incarcerated. So there's some major challenges. Next slide, please. We also know that Medicaid is the single largest payer in the country of mental health and substance use disorder services. But because of the inmate exclusion of Medicaid law, federal Medicaid dollars, with one narrow exception, do not pay for care. Medicaid dollars are not used to finance care while a person is incarcerated. So our project, with FORE's very generous support, which we very much appreciated, Legal Action Center was able to examine activity around the country. And this was really in virtually every corner of the country. There's recognition that people need to have better access to healthcare, better access to Medicaid coverage as such a critically important source of funding for people in the critical legal system, and that there's work happening in each of the states to try to really improve access to coverage as people are coming out of incarceration, to have different policies that, where there's eligibility screening and enrollment when people go into incarceration, making sure that people, again, when they come out, there are no disruptions in coverage, ensuring that there's good access to services upon reentry. So we did we did 2 issue briefs. One was focused on these coverage issues, and the second was really focused on different aspects of the Medicaid program that can be leveraged to better improve access to opioid use disorder, other substance use disorder care, mental health care, kind of the whole host of things that people need, knowing that Medicaid has a number of different initiatives that are focused on housing supports and nutrition supports, postpartum care, lots of different things that could really, really benefit people involved in the criminal legal system. And we were able to really identify best practices at each of these points. And we also developed policy recommendations that we were really pleased to share with federal policymakers, and very happy to see when I get into the detail of the California Medicaid reentry waiver, we could see that a number of those recommendations were adopted, which was gratifying and a good place to start. Next slide, please. So I'll speak more about Medicaid's reentry demonstration opportunity. And I'll just note here that I'll be speaking about California's 1115 waiver, which CMS approved at the end of January. We are awaiting guidance from Medicaid that guidance to all of the states through a state Medicaid director's letter, and that will give us more information about the parameters that they're setting. We're able to glean a lot of this from California's waiver, which will help us to have this discussion. But I just do want to note that we are all eagerly awaiting Medicaid's guidance. If I had to bet, I would guess that we would see it next month, which is Second Chance Month. And the federal government tends to release a number of announcements and initiatives related to helping people in the criminal legal system. So that would be my guess, but we are expecting to see this soon. So as I mentioned, Medicaid right now, federal dollars cannot pay for care unless somebody goes into an inpatient care facility, a number of different types of care facilities for more than 24 hours. But otherwise, Medicaid does not pay for care behind the walls. This is an opportunity that's been discussed for a number of years. It was first identified in New York by colleagues of mine in 2016, and a number of states around the country, again, red states, blue states, all kinds of different states, particularly those that have expanded Medicaid, knowing that under the Affordable Care Act, people who are eligible for Medicaid under the Affordable Care Act in the expansion population, primarily single, non-parenting, non-disabled adults, that 90% of federal dollars pay for their care. So this is a very appealing thing for states to appreciate, in addition to all of the good interest in trying to improve access to care and to decrease re-involvement in the criminal legal system for people who are coming home. So as I mentioned again, at the end of January, California became the first state to receive approval from CMS to move forward with their Medicaid reentry demonstration proposal. There are 14 other states right now that have pending proposals. So there is huge interest, again, from all around the country. Next slide, please. We'll go right to the next slide, please, too. Okay, so here is some of the detail. The purpose, the goal of California's Medicaid reentry waiver, again, it allows FFP, federal financial participation, or federal Medicaid dollars to cover certain pre-release services, which I'll walk through, to certain Medicaid and CHIP eligible people for up to 90 days before release. And this is important. Through legislation at the federal level, the Medicaid Reentry Act, which is focused on getting this into statute, the focus was 30 days. A number of states have asked for 30 days, 60 days, a couple of others 90 days, but it's very significant, I think, that CMS approved a waiver that does include this length of time. I think it is significant, understanding how long it may take to get coverage issues resolved and connect people to care before they're leaving. So wanted to first note that. So this is a section 1115 waiver. And again, the goals, they want to provide short-term Medicaid enrollment assistance and coverage for certain pre-release services to help with the transition into the community, to help identify and treat certain chronic and other serious conditions, to really decrease use of acute care as people are coming back home, and also test. This is like a function and a big attribute of a demonstration waiver. They're going to test whether pre-release services improves utilization and continuity of medication-assisted treatment and other substance use and mental health treatment to strengthen health outcomes and reduce suicide and overdose-related death. So again, a very strong focus in California's waiver around substance use disorder, opioid use disorder, mental health, and again, improving health outcomes and protecting people, keeping people safe. Next, please. So to participate, someone has to be either eligible for or enrolled in Medicaid, or eligible for CHIP, if not for their incarceration, to be incarcerated in state prison, county jail, or a youth correctional facilities, and be 90 days from release. Adults, people who are incarcerated in jails and prisons need to also meet health-related criteria, which I'll talk about next. But if there is a person who's incarcerated in a youth correctional facility who is eligible for Medicaid or CHIP and 90 days from release, they don't need to meet any kind of clinical criteria to qualify. Next slide, please. So going back to that health-related criteria. So to meet this requirement, a person has to have a confirmed or suspected diagnosis of a mental health condition, a substance use disorder, a chronic health condition, or what they identify as a significant non-chronic clinical condition, or an intellectual or developmental disability, traumatic brain injury, positive test or diagnosis of HIV or AIDS, current pregnancy, or being 12 months postpartum. Next slide, please. And again, that only applies to people in prison and jail, not to people in youth correctional facilities. Covered services, I won't go through all of them here, but again, heavy focus on mental health and substance use disorder, including medication-assisted treatment. Also pleased to see services for community health workers and community navigators with lived experiences. Also, all of these are very important to see, but again, this is all to kind of assess a person's health needs and to connect them to some foundational things before they're leaving. Next, please. Okay, eligible providers. Interesting piece of this, and we can have some more discussion. So Medicaid participating providers, providers that participate in the CHIP program, or carceral health providers. Although they do say that if carceral health providers are providing care, they have to allow and make linkages to community-based providers who can engage with people when they are released. They do have different requirements on participation here, and they do say that they should have necessary experience and receive appropriate training to work with people who are incarcerated. We'll come back to this, but next. Thank you. So a couple of quick things. So CMS is very clear that they don't want federal funds to supplant or to absolve states and localities from their constitutional obligation to provide healthcare to people who are incarcerated. They say that where there is new federal money that is coming in and that is paying for services that could have been paid for by state and federal and local dollars, that a condition of approval that CMS put on this waiver is that the state, California, has to reinvest funds to improve care. So that's for people in the community to help people avoid contact and incarceration. It's for people behind the walls. Again, I know this is focused on reentry, but this is one piece where they talk about improving the quality of care for people incarcerated across the board and people who are coming out. So there actually needs to be a reinvestment plan. That's one of the pieces that is required for California to fill out. Next, there's a lot of discussion about eligibility and enrollment, and I'm watching my time. I think I'm doing okay. So eligibility and enrollment, as I mentioned, and as I'm sure folks know, people often are disconnected from coverage at many different points while they're incarcerated. So eligibility screening and enrollment and suspending either the eligibility or the benefits while the person's incarcerated is required. That's one of the things that they CMS conditioned their approval of California's waiver on this. And I'll also note that they're very clear that they say that this eligibility screening and enrollment doesn't just pertain to the people in that 90-day window. They said that it relates to anybody who's incarcerated in a facility that's participating in this opportunity. So again, that would help to improve coverage and continuity of coverage overall. And so that's one piece of it. Data collection, evaluation, there's a heavy focus on evaluation. Again, an evaluation, there's an implementation plan that's required, like the reinvestment plan. So lot of discussion there. We were pleased to see, and this is a recommendation we made through our FORE work, to really consult incarcerated people, formerly and currently incarcerated people, knowing that this is all very new. This is a very different way of doing things, and really ensuring that people have good access to care, good quality care, have the ability to provide some choice in what their care looks like. Talking to incarcerated people in a way that protects them is very important. So we were pleased to see that. And the demo will start, so federal financial participation could start on April 1, 2024, and the demo runs till 2026. So just 18 months, which again, I'll come back to in a moment. Next slide, please. Okay, so last kind of set of things to talk about here. So next slide, please. Thank you. So yes, so I mentioned the forthcoming state Medicaid director's letter that's going to outline this whole opportunity and give some additional indication of expectations that Medicaid has, expecting it in the near future, in the spring. I, again, would guess April, but we will see. And they will provide, as I mentioned, guidance on kind of their expectations across the board. We will see likely some additional approvals of other pending state waivers. As I mentioned, we're up to 14 that are pending now. And again, I think with California's approval, it really signaled around the country to lots of different states that this is something that's possible, that this is doable, and that they too can develop a proposal. So I think we'll see a lot of activity. A lot of focus on implementation. This would be a challenge, knowing how difficult it can be for systems and in a cross-system way, when we look at health and we look at the criminal legal system, to work together to really meet all of these needs, and know that a lot of this is related to the community capacity of services and supports for people, and ways to really build and continue to invest in that infrastructure. There also will continue to be discussion at the federal level. I mentioned the Medicaid Reentry Act, which is going to be reintroduced, and again would be something to put in statute, what CMS is doing through regulation here. And again, lots of continued conversation, I think, in the states about all of this. So next slide, please. So major challenges that I see, challenges and opportunities. I'll start with challenges. So I think the first question kind of gets to this. When we think about patient rights, protections, benefits, and choice, and we think of a framework of a carceral setting, there's some challenges when we think of a carceral setting being characterized more by punishment and coercion. So how do we kind of layer these things on top of each other? How do we ensure that this works in a way so that people have good access to services and have good linkage to really culturally effective community-based providers in the community? I think I mentioned the cross systems issues, data exchange, technical assistance that's needed for these systems and these actors to work together. I think there are a lot of discussions about whether the federal government can play a role in that and can assist there. And then I would mention the states that haven't yet expanded Medicaid. That is certainly a challenge. Again, knowing that this is going to benefit particularly those states that have expanded Medicaid. And I worry about exacerbated health disparities for those states that haven't yet. I was pleased to see North Carolina. I know one of my co-panelists from North Carolina. That was good to see Medicaid expansion movement there. Let's move to, I'll just say on opportunities. I mean, again, I think the opportunities are really tremendous in terms of people having their health needs assessed and linked to care. And again, this real emphasis on mental health and substance use disorder services, medications. We know, and we've done a bunch of work at Legal Action Center around legal requirements to continue to provide medication-assisted treatment while a person is incarcerated, but we know that in most of the country, that's not yet happening. So this could be really, really critical to help keep people healthy and safe and to protect them as they're coming out of incarceration and to help them get into recovery. So that's something very encouraging. I think this whole concept of reinvesting dollars to help keep people out of the criminal legal system in the first place is really hopeful and promising. And I'm curious to see how states are going to approach that and really examine that. And I think the last thing I would say is that it's been a real mystery for many people what carceral health really looks like. It's not a very transparent system. And again, I think the goal for everyone is to help people be healthier and to help people avoid arrest and avoid rearrest and reincarceration as they come home, and to really strengthen communities, knowing that this will have really, hopefully, big implications. So a lot to do, but a lot of hope. Next slide, please. Thanks so much. I'm going to pass it over to my co-presenters. So next will be Dr. Eric Weintraub and Captain Daniel Lasher. So thanks so much. Looking forward to the question and answers and hearing my co-presenters' presentations.
Thank you, Gab. Appreciate Ken for inviting Dr. Dan and myself to present today. We're going to talk, I'm going to talk about a project that was funded through FORE that allowed us to expand access to medication-based treatment into underserved county jails. I first wanted to go through some background. Can you go ahead, Ken, and go to the next slide? So as everybody's aware, we're in the midst of a severe public health emergency. Here are some of the numbers that are absolutely staggering about the loss of life and cost to society. The major point I want to make here, because a lot of our work, even though I come from the University of Maryland and work in Baltimore City, a lot of our telemedicine work is engaged in increasing access to treatment in underserved rural areas. And what we've seen in the last 25 years has been a significant increase in the percentage of deaths that are now in rural areas. Opioid use disorder and overdoses used to be predominantly an urban issue. And since the overprescribing of medications, we've seen this change to the point where we're almost seeing a 50-50 percentage of deaths occurring in rural areas. Next slide, please. There's 3 medication-based treatments approved by the FDA, and the reason I put that up there is medication-based treatment for opioid use disorder is the gold standard evidence-based treatment. It's recommended by every major health organization in the world. It's been pushed by this current administration in an effort to expand access to this treatment. Is it the only treatment that's necessary for people to get well? Absolutely not. We often pair this with different types of therapy, contingency management, a focus on the issues that affect homelessness, mental health problems. So, but it is important and critical that people have access to this life-saving treatment. Next slide, please. And why is that? So this is methadone, buprenorphine have been studied for many years. Methadone for 50 years, buprenorphine probably close to 25 to 30 years. And we know that being on these medications, if you have opioid use disorder, increases retention and treatment, decreases illicit opioid use, and most importantly, decreases the rate of overdoses by up to 50%. You can see some of the other things, including social functioning improves. We see a decrease of infectious diseases and decrease in criminal activity associated with people being treated with these medications. Next slide, please. However, since initially opioid use disorder was predominantly an urban illness, most of the treatment infrastructure grew up in urban areas, and methadone was set up, and that's a whole nother discussion about why methadone treatment programs were set up the way they are, but they're predominantly in urban areas. And so many counties in the United States, most of them rural, do not have a facility offering any type of MOUD. And you can see the numbers there, that it's very difficult to access care in rural areas for a variety, just due to lack of access. And even if there are methadone programs, having worked in some of these areas, it's very difficult for individuals to get there due to the tight regulations that require almost daily attendance for many individuals. Next slide, please. So we know, and Gab talked about this a little bit, that incarcerated individuals have a heightened risk of overdose, especially if they have OUD. Here are some of the numbers. Close to 65% of individuals have any SUD or substance use disorder. Approximately 15% meet criteria for opioid use disorder. A significant percentage of deaths upon release from jail involve opioid overdose. And there's certain studies that show dramatic increases in the first couple weeks to a month after release from jail, incarceration. And we think there are 2 major reasons for that. One is when people go to jail and they aren't treated with medications, they have no tolerance. And we know that the illicit drug supply is so lethal right now with fentanyl and other adulterants that people are at really high risk if they go out without tolerance and go out and use illicit drugs, especially in rural areas where sometimes people have more of a tendency to use alone or in more socially isolated. Next slide, please. This is information that I got off a website called, let's see, it was called the Jail and Prison Opioid Project. And you can see that many correctional facilities do not offer medications for opioid use disorder. And those are some of the numbers. So there's a lack of access. So people, and we see this clinically. I treat people on other platforms in rural areas. We see people actually doing well on medications. They may get incarcerated frequently for an old charge, or and they go into jail. They're pulled off their medicines. They go through withdrawal, and it really creates kind of havoc with their ability to recover from their substance use disorder. Next slide, please. There's a couple studies. Well, there's more than this. If you look at the sheet that was put out today, there were several studies that have demonstrated that putting individuals or treating individuals with medications such as buprenorphine and methadone effectively decrease overdose deaths and recidivism. Here are two studies that recently came out, and I don't have, unfortunately, the citations on the slide, but I can share them with you, that demonstrate that individuals that were treated with, in the first study out of New York, people that were treated with medications for opioid use disorder up to 3 days prior to release had an 80% reduction in overdose mortality risk. And that's in the first month after release from jail. Another study recently out of Massachusetts compared two adjacent counties, one that offered buprenorphine treatment and the other that didn't. And those that were on buprenorphine were significantly less likely to have recidivism, which was related to probation violations, reincarceration. So those are the two things I think that we're looking for, that we want to see decrease in, two of the things we're looking for, decrease in overdose deaths and decrease in recidivism, especially from the correctional standpoint. They want to see that this works and this is effective and this helps prevent re-entry into their system. Next slide, please. So just to go back, without going into too much detail, we got into the telemedicine space long before COVID. We got approached by somebody in a more rural area of Maryland. And again, I know rural in Maryland, it's not rural compared to certain other states, but he had lost his buprenorphine provider, asked if we could help him out. We actually had already burgeoning child psychiatry telemedicine program. So we, Dr. Chris Welsh, my colleague, and I said, sure, let's try this. And we found that it was a very effective, successful way of sort of piping out some of our expertise into areas that didn't have clinicians or people that could prescribe buprenorphine. Now, things have changed in the last couple months, but up until recently, you had to have a waiver, and finding a waiver prescriber was quite difficult. Over the last several years, we've tried to develop some innovative models where we think they're innovative to help expand access to this type of care, even developing a mobile van that allows us to run clinics in different small counties while we have actually clinicians on the ground, counselors, nurses. The docs are in Baltimore doing the telemedicine prescribing and doing the evaluations for patients. Next slide, please. Yeah, so we have we've had communications or collaborations with county health departments throughout the state, substance use treatment centers. We have our mobile unit that's now in 2 counties, with the state has just provided us with a second van, so we're going to be able to operate 2 vans at once. And then around this time is when we got the idea, or we saw clinically, that many of our patients that we were treating, they tended to be fluid. They would go into emergency departments, they would go to jail, and to try to provide opportunities for them to have access to treatment in all of these different environments, we thought was important for them to actually achieve recovery. So FORE funded us to try to implement a tele-MOUD program in 3 county jails. And fortuitously, right after we got the grant, Maryland passed a law called HB 116, which mandated that by January of 2023, which is this past January, that all the county jails in Maryland had to be able to offer all 3 types of medication for opioid use disorder to their incarcerated individuals. Next slide, please. The essential program elements that we've found that are critical to make this work, that we have to have standard operating procedures. A program champion is very important. Coordination between the different teams. So in these jails, we're working with not only with our team, but we're working with the contracted medical team. We're actually working with the health department, and most importantly, the correctional team. When the wardens or captains, they're the most critical person, because having these types of programs takes a change of perspective, and it's work and effort and expensive for the correctional team to be able to operate and run these types of programs. Next slide, please. I'm running out of time, but so these are the 4 teams that we kind of coordinate with. Our tele team, like I said, the medical team, which changes from site to site. The health departments are invaluable in making sure that we have aftercare and follow-up appointments. And then the buy-in by the ward and the correctional staff is critical. We found that having so we're in 6 different states. I think the map may come up next, but each implementation has been totally different, depending on who the warden is, who the nurse is, who runs the health department. So we've kind of be pretty flexible about how we approach the implementation of these programs. Next slide, please. These are the counties in Maryland that we're actually operating in. The gold or the yellow or gold star is where we operate out of in Baltimore City. And you can see we're predominantly on the eastern shore of Maryland, although we are in Western Maryland as well. And Dan's going to talk about that program. I try to, we're a small enough state that I travel and visit the jails when I can to make sure that we have a personal connection there. Next slide, please. So here's some preliminary data from the Allegheny County Detention Center. Since 9/1/22, about 50% of inmates have screened positive for opioid misuse. We've had 319 different admissions into the program, which represent 270 unique individuals, because some people have been reincarcerated. We've treated 283 patients that have been released, and at any one time we see there are 25 to 35 patients in treatment. I did my clinical session yesterday morning, and there were 35 patients actually in treatment at that time. The jail houses about 180 people. Next slide, please. We are gathering outcome data. Right now, what we have is we know that we frequently write bridge prescriptions to patients that are being released. And of the first 69 that we wrote bridge prescriptions for, we were able to determine that 58 or 84.1% have followed up and filled that prescription. We have some more comprehensive data that we're going to kind of follow these patients out for more months. And also, we're also confirming who and how many individuals may have died or had overdose deaths, non-fatal overdoses or overdose deaths. Next slide. And this is just about the acceptability and sort of the buy-in from support the leadership and staff at all levels, which is so critical to success. I think that's my last slide. I don't know if Ken's going to introduce, but Dan Lasher, who has just been he's a great guy and has really been helped us get this program up and running in Allegheny County. The warden is going to take over. And thanks, Dan. Good to see you.
All right. Thank you, Eric. That's awfully nice to say. And I appreciate being able to have a little bit of time here just to speak about our program. So as Eric said, in 2019, Maryland passed a law saying that they had a few pilot programs, and they said all the counties had to be on board by January 1 of this year. So we took an opportunity a year and a half, 2 years ago to jump into this thing, and we started at a smaller level, and then the opportunity came to work with Dr. Welsh and Dr. Weintraub at the University of Maryland. And it's been nothing but success for us since, at least in the the numbers that you just saw. It would be nice if everybody could roll out of here totally recovered, but we know that's not going to happen. But the difficulties and some of the hurdles I want to talk about today is that, you know, and myself being involved, you know, when I was being forced to do it from the state, I can't say I totally bought into the program. I've always wanted to help people. I've always said, as an administrator, wanted people who were incarcerated to be able to leave and become better folks, but I wasn't necessarily convinced that we could play a big enough role in their treatment and actually see some success. And I'm here today to prove I've been proven wrong on several occasions. And one of the hurdles that we're seeing here is, it's for anyone looking to do this particular type of program, it is difficult to get your staff to buy into. And correctional staff, as you can well imagine, their primary function is safety and security while they're within a facility. And we have a lot of ancillary staff that work in treatment, and the correctional staff don't buy into that as well. But as I get some of these folks to do that, the treatment becomes so much more important and so much more intense, because even the officer who's locked in with that inmate is becoming a piece of the treatment process, because they are sharing and they're conversing with these people, and they're helping them down that particular path. But it's a hurdle, and we've learned that, and we've learned to introduce training into our in-service that helps to work to facilitate the people with our MOUD program. We are working with our peer recovery specialists. So in Maryland, you know, it was not only bringing in you know, all three types of medication, but there had to be counseling involved. There had to be peer recovery specialists, and there also has to be avenues to get you to treatment when you leave here. So all of those things are happening, but bringing the peer recovery specialists in was very eye-opening to a great deal of my staff, because these folks were sharing their story and showing them that, you know, recovery is possible. And when they work with these inmates and the staff then see the success that happens, and the difficulty there, if you think about it, the success is that you don't come back, or if you are back in my institution, that you're not back positive, because of course we urine test everyone who comes in. So if you're clean but you're still going to you're going to your clinic, or you're seeing your doctor on the outside and getting your medication, it's a real bonus. But we seize every one of those things and try to exploit them so that we can buy more staff into this. Anyone looking to do this program, I don't know that I can emphasize much more that, aside from setting up that core team and having a good relationship with all of your providers, is then getting your staff to buy into it. And don't think I've got everybody on board. I don't, but that doesn't mean I'm not going to continue to try. So, you know, that's one of the particular hurdles. And when Eric talked about serving rural Maryland, by the way, of that map that you saw, there were all those flatlanders down there close to the ocean. But we sit in the middle of the Appalachians, and we were once a county of, you know, back in the 50s, I had 90-some thousand people that lived here. And we're down to under 70,000 people now. It was an industrial area that has declined. So, but we still have a great deal of infrastructure to keep up. But what you find is your unemployment rate's a bit higher, and that the difficulty of footing the bill for these types of programs is extremely difficult in rural communities that are working to keep schools going and other things, just as anywhere else does in the country. So our program runs us about $250,000 a year. And that's still a bit underfunded, because there are things we could be paying more for, and certainly for physician care, for and other staff that we have, that we could better fund them. But in Maryland, everything is grant funded for this program right now. And they've done a fine job of getting some of that money out, but it's not going to be enough money. And we're pushing for the state of Maryland to continue, or to adopt it into their state budget for the locals to be able to be funded for this program, since it's mandated. But it brings me back around to what Gabby talked about, and that is having, having Medicaid become a bigger part of this picture, so that we can better facilitate setting these folks up for their past few, or their last few months in here, getting them into a treatment program, getting them out into a funded facility that'll continue their recovery. And another piece that I didn't want to forget one of the hurdles that we're also seeing too is that Dr. Weintraub could have expressed is that anyone setting this program, we have a difficulty in the community at times getting people to fill the prescription. Pharmacies apparently, depending on who you talk to, get a certain amount from their distributors of these medications. They protect their regular customers. They don't want to appear that they're over filling prescriptions to people. And also in our situation, our physicians are in Baltimore. So when people get released in rural Maryland up here in the mountains and they go out, the pharmacies kind of give them a, little double look to see if they if the prescription is legitimate. So it's just a little bit to try to show you some of the hurdles that we have in the program, but we've been very successful, as Dr. Weintraub said. We also are collaborating with another doctor here, Dr. Michael Gordon and Friends Research, and they're going to be doing some follow-up as well. The data piece that he talked about is extremely critical, because if we can show the success, and as you know, working with addiction success rates, it's not like a kid getting an A on the test. The numbers aren't going to be that high, but I think we can improve, and I think we already have improved, and we're showing that if we all work together on a team with it, this thing can be beat. And I have people here who've come to jail 30, 40 times, and the majority of those times are all drug-related crimes. And they're not harming other people, they're harming themselves, but they are harming their families. So we need to really take the bull by the horns on this problem and see if we can't make some sort of a difference. And I think this program, I think these grants, and I think all of you folks working together are really, should be commended. And I wish I could see all your faces on the screen, because I tell you all, thank you very much. And with that, I'm finished with my part. So I'd like to introduce Essence Hairston, Program Manager of the University of North Carolina Horizons Program.
Hi, I am so excited to be here. I will say, Captain Lasher, I think we need to clone you and place you throughout our nation. Today, I will be talking about reimagining care for pregnant and postpartum women during and after incarceration, if North Carolina followed California's 1115 waiver policy. Next slide. Here are the objectives for today. So I'll give you a brief overview of our GENIS project, which was funded by FORE, and some of our expanded reentry services. I'll discuss some policy implications following the approval of California's 1115 waiver, and thinking about what if North Carolina actually adopted this amendment. And then also I will provide recommendations for the field. Next slide. So GENIS project was a 2-year pilot where we work with pregnant and parenting women transitioning out of a state prison here in North Carolina, specifically the North Carolina Correctional Institute for Women. What motivated us to facilitate this project was a former Horizons graduate by the name of Jenna, who upon completion made the decision to return back to her home county. And at the time, when she returned back to her home county, she got reconnected with unhealthy people and then returned to incarceration. At the time of Jenna's release, within 24 hours, unfortunately, Jenna passed due to a opioid-related death, and she left behind 4 children. And so in her honor, in her memory, we wanted to ensure that we were addressing this gap and specifically looking at it from a gender and trauma-responsive reentry model. So our GENIS project comprised of an interdisciplinary team that provided comprehensive care coordination upon release for up to 6 months from the release date. We connected with the OBGYN department, NCCIW staff, so DPS, now the Department of Adult Corrections, case managers, social work team, as well as the mental health and healthcare team, UNC Family Medicine, as well as UNC Psychiatry, and a ton of community agencies, as well as local reentry councils and probation and parole. Our main milestones for the GENIS project was to meet 50 pregnant people or postpartum people right at the door to reduce opioid-related injuries and deaths. Next slide. So here are our outcomes. Since post the 2-year project, we were able to not only just connect with one prison, but we were able to connect with 2 prisons throughout the state of North Carolina. Anson Correctional is actually the state's women's reentry prison here in North Carolina. We also worked with 40 jails in North Carolina, as well as supported a transition back to North Carolina for a postpartum person who was leaving a federal prison in Carswell, Texas. We were able to reduce perinatal incarceration by intervening at the jail level, as well as exceeded our 50 participant milestone. So at the point of the project completion, we were able to work with 132 unduplicated pregnant and postpartum women, with only 1.5% returning to illicit substance use, 0% of opioid-related deaths and/or injuries. And in 2021, we were able to integrate the first prenatal SUD clinic, where we embedded behavioral health counselors and SUD counselors to provide evidence-based therapy, as well as counseling, and also to create this continuity of care that really strengthen our reentry services. Next slide. So in 2020, what we noticed was we were having a hard time getting individuals at the time of release. As you can imagine, we actually facilitated this project in the COVID-19 pandemic. And when I tell you it was brutal, having to navigate a pandemic during the epidemic, it was very crucial. And so in 2020, along with Dr. Andrea Canetto, who's also a co-I on this project, as well as a OB doc at the prison, and we submitted a proposal to North Carolina Correctional Institute to advocate for integrating perinatal substance use counselors in the prison. And at 2021, we were approved to officially create what we know as today the first integrated prenatal SUD clinic at a women's prison. How we materialized that project was actually utilizing Dr. Elizabeth Johnson. Her picture was on previous slides here. We utilized a blueprint that she had for her clinic and implemented and adjusted that to meet the structure of the women's prison. So when pregnant people would enter into the health facility at the women's prison, we would provide counseling prior, before, and or after their OB visit. We had a licensed clinical addiction specialist. We had a substance use case manager, provided comprehensive care coordination. So thinking about that continuity of care. We provided, again, individual counseling before and after release, embraced evidence-based models and culturally relevant services, psychoeducation, coping skills, and we were able to transition, create those transition plans. And what we noticed was that the importance of pre-release and catching individuals prior to them leaving incarceration. Next slide. So FORE was so fundamental in the expansion of a lot of our reentry services that I will talk about today. I feel like we owe them pretty much everything. So upon completion of the pilot project, the GENIS project, we were able to submit a proposal for Empower, which is engaging and motivating preventing overdoses among women via effective reentry. So utilizing that FORE data of working with pregnant and postpartum women, we're now facilitating a statewide pilot project looking at all women identified people leaving all 3 state prisons here in North Carolina. So our Jenna's project looked at pregnancy, postpartum, and now we're looking at working with individuals with the substance use history prior to incarceration and connecting them to care. We facilitate this as a hub and spoke model, and we have the same framework. So utilizing an interdisciplinary team to provide comprehensive care coordination upon release, and we'll also follow them for 6 months from the release date. We provide telehealth or telebehavioral health services so we can connect with individuals at those prisons, as well as able to provide in-person services. And we are fortunate enough to be DPS or adult corrections now, having to get used to the name change. I'm contracted. So being able to have that strong relationship with the prison has been very monumental as well. Our current milestones for our Empower project, our goal is to meet 400 participants at the time of release, as well as reduce opioid-related injuries and deaths. At the time of the project start date in September, we actually received 30 referrals in 1 month at one prison. And so we are eager to get more staff so we can meet the needs of women leaving prisons in North Carolina. Next slide. So what we also noted, looking at the trends, is that we were able to increase access to medication for opioid use disorders, as well as connection to case managers and physical health care. But one of the things that we had a hard time addressing was the social drivers or the social determinants of health. So when we're thinking about increase in access to treatment, we also have to think about all of the other socioeconomic factors that may impede the recovery and reentry process. And so by doing that, we also submitted a proposal utilizing the Jenna's project data to submit funding to have the first perinatal incarceration transitional housing for pregnant and postpartum women leaving prisons, as well as we will have a family unit to promote reunification and visitation for women and children. We would like to address social drivers, again, reduce health, racial, and social inequities among pregnant or postpartum people leaving prison in North Carolina, as well as mitigating caregiver-child separation due to substance use-related charges. This is really important to know. I'll talk a little bit more about safekeeping in the next upcoming slides. But any pregnant person that enters into a women's prison, almost 100% of those individuals will have some type of CPS involvement. It is unfortunately just the protocol that's happening right now, what they call a birth plan. And so our goal is to keep that dyad together. Thinking about gender responsive reentry, as we all know that most women incarcerated are all indicating primary caregivers before incarceration, as well as a lot of individuals who are incarcerated are not familiar with their rights as a caregiver. Currently, we have 5 fully furnished apartments and a housing manager in Wake County. So when individuals leave prison, if they are wanting to continue treatment with us, we will support them, move them into a fully furnished apartment in North Carolina. They do not have to ask for anything. The only request that we ask for them is dedication and commitment to recovery, into integrating back into the community. They will also have access to their own case manager. So it's a dedicated case manager for that role, but also will be connecting with doulas and the local health department, as well as we have a primary care provider, therapist, as well as onboarding a maternal and child therapist in the future. Again, below, this is some of the behavioral health services that we provide. Next slide. Thank you, Ken. All right, so objective 2, let's move to policy implications following the approval of California's 1115 waiver. Next slide. So if we were able, we in terms of North Carolina, we were able to embrace the 1115 waiver, this is what we will request from jails and prisons. And the reason why we put jails and prisons, because we recognize that there are different intervention and fundamental needs for those two institutions. Oftentimes you'll hear those terms used interchangeably, but here in North Carolina, we can actually see the difference and know the difference in terms of what that looks like in terms of release. So what we will request is DPS workers will submit healthcare applications, whether it's new or renewal, 3 months prior to release, if not before. So anecdotally, we know that although 3 months is beneficial, being inside a women's prison and specifically working with pregnant and postpartum women, 3 months is actually not enough for whether it's suspension back to activation or no history of Medicaid itself, but at least we know that 3 months will be beneficial to waiting to that last day. We will request that all pregnant and parenting women have uninterrupted healthcare coverage when they leave jails and prisons, including extending coverage up to 1 year post-delivery. So again, we know that the postpartum period is one of the most vulnerable periods for pregnant and or birthing people. I want to make sure that individuals are able to access healthcare immediately following. So we're looking at access to prenatal care, also access to primary care, but then also being able to access those prescriptions that Captain Lasher mentioned earlier. We also will request collaboration with behavioral and physical health providers to augment those service gaps, including contracting with county-driven Medicaid and Medicare managed care organizations. So here in North Carolina, we have what we call LME and MCOs, and each county is able to decide on how they disperse their funding. So there's not a consistent or continuity of funding allocation. We'll also request that all agencies, jails, and/or prisons maintain an electronic medical record to ensure that continuity of care and prescriptions can occur at each entry point or transition. And I'll talk to you in a second about the importance of that electronic medical record and continuity of care, specifically for working with pregnant and postpartum people and or women in prison. Next slide. So other policy implications we'll request is ongoing access to medication for opioid use disorder. As we know, in 2023, the revision of the Omnibus bill, removed the federal requirement for waiver registration, which removed that notice of intent that providers had to provide in order to actually prescribe buprenorphine. And that removal of the waiver registration will increase the flexibility of prescribing buprenorphine in jails and prisons. So here in North Carolina, pregnant women are the only population that can access medication for opioid use disorder, and is mainly to maintain the pregnancy. And so when someone delivers, they are immediately tapered off of their medication for opioid use disorders. And there's structural barriers with that, as well as social barriers with that, as jails and prisons are often not equipped to financially support the needs of those highly federally regulated programs like OBOTs or OTPs. And so having a family medicine provider on site that most prisons or jails already have on site will be able to increase that flexibility to access and buprenorphine. Next slide. We will also request a reduction in the use of safekeeping practices. So safekeeping is a practice that originated during the Reconstruction era as a form of discipline and enslavement of Black men and women throughout the Southern states. And what we see here in North Carolina is how structural racism continues to impact minoritized and vulnerable populations. So here in North Carolina, safekeeping is the involuntary movement of a pregnant person from their county jail to a women's prison, despite their conviction status. It is typically because the jails are not equipped to provide the care that they need for pregnant people. And so oftentimes, safekeeping implies that men and women are either have complex medical and psychiatric diagnosis that, again, cannot be treated in their local jails. But also, when someone is transported for safekeeping, it is unknown, meaning that the person, and I will, in this sense, I will say pregnant, even though safekeeping is a larger definition or process policy for all individuals that may have medical or psychiatric complexes. But for this webinar, I'll be referring to it as pregnancy. So pregnant women are not informed that they will be transported. Families are not informed that their loved ones are being transported. And sometimes judges and or district attorneys are not aware of the safekeeping protocol. And so they may do a CRV, which is pretty much like a 90-day, let's say, probation violation, and not realize that this pregnant person will have to be transported to the prison. And so we will request that pregnant and parenting women are offered perinatal and maternal substance use treatment programs as a form of alternative placement. So what we do know is that incarceration is not an effective treatment modality. So instead, we would like to request alternative placement so individuals can get the care that they need. Here in North Carolina, people leaving prisons are 74 times more likely to die from an overdose 2 weeks post-release. We'll also request that jails contract with physical and behavioral health providers, including patient navigators with lived experience, to avoid the transition to prison. Next slide. So now recommendations for the field. So our recommendations will be to implement transdisciplinary collaborations. One of the takeaways that we embrace during and after the FORE or GENIS project was the importance of working across different teams. So working with attorneys, probation, parole, and local reentry councils, workforce agencies to promote employment goals, as well as your comprehensive physical and behavioral health services, child welfare and protection, as individuals leaving prison now have to still interface with child welfare as well as the legal system in some capacity, as well as housing specialists to identify safe and validating housing. Next slide. We will also want individuals to engage in gender responsive recovery and reentry planning. So acknowledge the parallel of recovery and reentry and the limitations that impede successful transitioning efforts. Similar to women being able to access treatment. At the start of addiction treatment, it was focused primarily on the needs of men. Prisons and jails were built on the needs of men. And so what we see is this lack of gender responsive care that actually meets the whole needs and the unique needs of women leaving prisons. We recommend that transition planning start at 6 months prior to release. That includes a comprehensive clinical and case management assessment. And so looking at expanding that 3 months to 6 months, we've also witnessed success rates when we connect with individuals 6 months, even to a year upon release. And From a treatment or behavioral health perspective, we always say discharge and transition planning actually happens at the date of admissions. But again, we know there's other limitations there. Also, facilitate culturally responsive recovery and reentry treatment plans. Again, we know that there are needs, various needs based off of diverse backgrounds, and even looking at subpopulations. So looking at the intersectionality of race, sex, and also ableism will determine individuals' treatment needs and plans, as well as provide comprehensive referrals that support recovery, physical health and reproductive health, as well as sexual health and women's autonomy. The next slide. So what can you do today? We can inform providers of the removal of the ACTS waiver registration to expedite the access to buprenorphine. So recognizing that that's no longer a barrier for individuals to access MOUD. It is important that we all understand the historical context of treating substance use during the perinatal period, as well as be informed of the safekeeping laws in your state. Ensure that court officials, jails, and prisons are informed of treatment options and provide a menu of options as alternative options to incarceration, as well as be informed of the evidence-based treatment programs in your county and state to help tailor recovery and reentry services for women leaving jails and prison. And I think that's all of my slides. Yes, thank you.
Essence, thank you so much. And I want to thank Gabby, Eric, Daniel, and yourself for a real tour de force. These were incredible presentations and lots of terrific comments generated in the chat as well as in the questions. So we've got a few minutes and we'll get everybody back on camera and try to keep the conversation going. I want to thank the audience too for your engagement and for lots of terrific positive feedback as well as questions. I'm going to go back to the beginning and start with Gabby. A number of questions around both what other states are teed up, who are the 14 states. So if you can quickly shout out to that. And then questions around the intersection of Medicaid expansion and this waiver. So if you could talk a little bit more about, do you have to have one to apply for the other? Are there states that are going ahead with a waiver even if they don't have expansion? So.
Sure, appreciate all of that and really enjoyed listening to everyone else's presentations. Thanks for all the work. So the quick list, Washington, Oregon, Vermont, Montana, Utah, Arizona, New Mexico, West Virginia, Kentucky, New York, Massachusetts, New Jersey, Rhode Island, and New Hampshire. So those are the pending ones. But again, I think many other states, especially with California's approval, are developing proposals. And so I'll note that all of those are Medicaid expansion states. So just to go back quickly, so under the Affordable Care Act, before the Affordable Care Act, the only people who could qualify for Medicaid had to be pregnant, parenting, have a disability, and pregnant parenting, have a disability. And so this eliminated so many people in the legal system who are single, not custodial parents of children. And so with the Medicaid expansion, that was really the first time when, looking at income, but also again, removing those categorical restrictions so people are able to access Medicaid. So in the non-expansion states, it means that fewer people will be eligible because fewer people who are incarcerated are Medicaid eligible. We will see what happens. Again, I think the 90% federal dollars is a big carrot and hopefully will be a big incentive for states and again, to help people get healthier and to help avoid additional involvement in the criminal legal system. But we will see. It'll be interesting. Again, encouraged by North Carolina's actions and hopeful that other states will continue to move forward in that way.
So if a state is a non-expansion state, those categories of populations that those still apply for the waiver. So you'd only be able to use it on populations that fit one of the other categories.
Correct, and meet the income requirements.
And meet those. Right. Okay. And pending, there's a question about what does pending mean? So
pending means a state has developed a proposal and is engaging with CMS, the Centers for Medicare and Medicaid Services, around it. So we are aware of that. It's a good question because there could be other states that are in more initial stages, but again, are negotiating to develop a proposal and are working with CMS, but we haven't seen that yet.
And one more for you around the logistics of submitting a waiver was a question around who submits the waiver, you know, at the state level, who takes that lead and who submits that?
Sure. So it's the state Medicaid agency. And so this really emphasizes the need, and I appreciate, Essence, all of your kind of points at the end on action steps that people can do. I think regardless of whether your state is developing a waiver, having a relationship with your Medicaid agency is really important, and emphasizing the needs of the people you serve is very important. So regardless, that's going to be a locus of a lot of activity moving forward.
Great, thanks, Gabby. So Eric and Dan, a number of questions as well around the program and how it works. Let me start picking up on a couple. Eric, maybe to start with you in terms of the data, and this is something we highlight in the issue brief, which came out today as well. You know, the challenges of beginning to develop the outcomes data and being able to track people after they've upon reentry, and to look for those longer term outcomes in terms of reducing overdoses and keeping people engaged in treatment. So there were some questions related to that. And do you have anything else you'd like to add in terms of how to help think about building up those databases and developing outcomes measures?
Yeah, so that's a great question. I think obviously they're critical. I think one of the major discussions that Dan and I always have is he says, show me the data, because for him to be able, you know, he was very clear. I mean, he was clear in his discussion today that for correctional officers, this is a big thing to be giving medications like this in jail. And it's one thing to say, it works and it's good. And I've been calls where, you know, say, you know, you don't understand what really is happening in the jail. So we need those outcome data. We're starting, I mean, we shared some studies. I think what you put out today also showed some data that I think we're a little bit better at showing that people are not overdosing at the same rates when they're being discharged on these medications. I think we need to do a better job of seeing about linkages to treatment, and also how long. I mean, I think the responsibility of linkages and how long we need to look is, I mean, I think if you can say that somebody's actually got engaged in treatment and was treated for a limited amount of time, that's kind of the responsibility of the jail and the jail-based program. Once they get to the outside and they're engaged for a certain amount of time, I think the emphasis shifts that it's really the outpatient program that needs to do, you know, not be held accountable, but we've done our job. We've gotten them out their own medicines. They've been engaged. They've had 2 or 3 appointments. Then it's really not looking back at the jail program failed or not. It's whether the other issues are involved. So, I mean, one of the things I think, and I'll just stop here, if Medicaid expansion does go forward, I don't know if we talked, Dan actually mentioned this, but injectable medications, especially Sublocade, could be a huge benefit, not only to the workforce issues that we're seeing in the jails, but the linkage to outpatient treatment, where you don't have to worry as much about a bridge and getting you know, people to a pharmacy, which can actually be an issue in these areas. So if somebody has a shot, can get a shot of Sublocade right before they walk, or maybe 2 shots, get a level and walk out the door, I think that would really be an effective strategy and a way to kind of utilize our program and what Gabby's doing together and creating linkages to the outside.
Great, thank you, Eric.
Yeah.
And Dan, to pick up there, whether there was a question about concerns, whether you had concerns around diversion of buprenorphine within the jail, and how you. So I know that you know we saw a demonstration of how you have your team has addressed that. So maybe start there.
Well, you know, as Eric was saying, I want to just real quick before I lose that thought, when he talked about Sublocade and getting outside and that was where the Medicaid piece came in, because it's an expensive injection. But the folks that we've had that have gone out, and I saw Julie was online here in the article, she emphasized some of those folks, and they said, boy, when they didn't feel like an addict because they weren't going to a clinic every day. They weren't seeing other addicts. It was once a month, and then they were going to work. So it changed their mindset about who they were. And so I do think that I certainly don't know as a detention administrator how it feels or what how the medication is working for that individual. But I love the fact that if they're not feeling, if it's handling their craving, they're not wanting the drug, and they're feeling as if they're succeeding because they're not associating with other folks. That's fantastic. But here on the inside, oh goodness, even lost track of where you were.
The diversion. About diversion.
Yeah. Well, you want a specific on what? As far as,
was there concern among the staff in terms of the buprenorphine being?
Their issue here is again, as I said, they're all about security. And when they see inmates, you know, they're going to tell you that you're trading one drug for another. They're just doing it to get high. And when they do catch individuals who are trying to cheat the system, see, that only emphasizes what they're trying to say. So dealing with those folks, and Dr. Weintraub's done a wonderful job of, you know, giving some folks some chances and some others saying, look, I don't think you're serious about your treatment. So, you know, they do get removed. But when you see those folks that come in every day and they do, and they have jobs inside the facility too, there is a level of trust that the correctional staff, no matter what, whether you're in a facility for murder or whether you're in here for a DUI or some violation of probation or whatever, we're all human, and we have interactions with these people every day. So there's a level of trust that you have. And when you start seeing people are clear and coherent, they're dedicated to their time with their counselors, they're dedicated to time with their peer recovery specialists, they start to have a behavioral change, then it's very easy then for anyone to buy into that program. So getting my staff to see that, and that's what it takes. It does take that interaction. If they distance themselves and just want to watch to try to catch people doing something wrong, then you know, it's an uphill battle for me. But I think, again, one of the things, and we'll work towards here at the end of this year, I think we'll look to the training commission in the state and look and see if we can't make this type of a program and the awareness to new people who are going through an academy to be aware that it's more than just safety and security, and it's more than dotting your I's, crossing your T's, and reports and things that you learn through the academy, but you can be a part of changing someone's life, and whether it's for drug diversion or whether it's, you know, keeping someone from wanting to commit suicide. The more that you interact and the more human you become with them and interact with them, I think the better you'll feel about yourself, to be quite honestly, at the end of the day.
Well, that's right. As Essen said, we need many Dan Lashers around the country. So I think that starting with those in training and communicating, that is a great start towards that. Essence, I'm going to keep going around because I'm keeping track of the question. But there were a couple of questions around how you, just in terms of setting up the Jenna's project, and then the current work now, the thinking around the 6-month time frame following women staying connected in the 6 months after release at reentry. There were some questions on how you decided about, you know, to use 6 months as the time frame.
That's actually a good question. I think that's the standard of what we provide services in terms of our traditional outpatient, in terms of so we have here at Horizons, we have a variety of services enhanced, and then also so looking at every level of that ASAM placement criteria. And so for our traditional outpatient model, we work with individuals on average 6 months to a year before we kind of transition them out to another setting. But I'm sure Dr. Jones, who could not be here today, may have more of a research and evaluation response to that question. But specifically, one is also look at long-term, being able to look at, again, 2 weeks, 1 month, and then the 6-month mark. But for me as the behavioral health provider, looking at it from the services that we currently provide for non-incarcerated folks leaving.
Right. Great. Thank you. Dan, I'm going to circle back to you around the question, because just before we started the webinar, you were talking a little bit about the success you feel when you're able to see people linked treatment following release. And there are a few questions around that, those gap community resources to connect people, and perhaps the role that FQHCs might be playing in this, other resources. What's been your experience in Allegheny County? And then maybe I'll ask Eric and Gabby to comment too.
Well, part of what we hired a reentry coordinator, or we had one, we hired another one when this program started, because we had to be a little more aggressive to make sure that wasn't just getting someone a ride from jail to home, that we had to get them to a clinic, into a program, set up with some counseling or whatever. So it's been very good. And we're about to bring on another person because we're seeing that success. And that's what I was mentioning, the number of people that we have in rehab that are leaving here. They may be in our facility held without bond, so the judge doesn't want them going anywhere, but he'll send them off to a treatment facility. And we've had a few come back, absolutely, but far more, and without running the number, I top of my head, 95% of them are still there or have completed and come back. But we've had a couple failures, but that's a tremendous number. Now, they're motivated too, because they want to. They don't want to be in jail. It's the facilities, the treatment facility is a little more relaxed, but nonetheless, we're facilitating that by having the reentry coordinators here and putting them out. And where I see, and I will tell you, I've been in this for 32 years, and I tell young folks all the time. Nothing makes me feel better than to see my employees happy, or when I run into people who've been in here who are successful on the outside and who are happy, or who thank me because you treat them like a human being. And, they genuinely understand that even when I was working as a slick sleeved officer, they knew that I would do what I could to try to make their life better. And you can't do any, you can't let them out. You can't give them things, but nonetheless, you are always working to try to be positive and try to make their life better. And for the folks in this situation, it's trying to get them into treatment and to emphasize how good the treatment is and how much better their life can be if they get this monster off their back.
Thanks, Dan. Well put. Eric, there are a few questions related to longer term treatment. So for people who will be in jail for much longer periods of time, or prison for much longer periods of time. I know Gabby certainly 1115 focuses on the last few months or weeks, but are there medical recommendations or protocols that are being developed, Eric, that are really to address people with longer term stays and how to manage their medication?
So it's interesting, in the bill that was passed in Maryland did not, it was only for the jails and not the prisons. And I think there's some debate about, if somebody's in jail. I saw one of the questions, like, if somebody's in jail for 20 years, do we treat them? I mean, if you ask me as a physician, I'd say yes. I mean, you would treat any other medical disorder. If somebody had diabetes or high blood pressure, you would treat them. Why wouldn't you treat somebody with opioid use disorder? But then I don't think there's a consensus throughout the systems, the different interlocking systems about how that's going to proceed. And I think sometimes it depends on who's the governor and who's in charge of the different states that are going to make those decisions. Why they left the prisons out in the bill, I don't know. I wasn't involved in crafting it, but right now we have an issue. So if I'm treating somebody in Allegheny County and they're on buprenorphine and they get transferred to prison, I have to taper them because that treatment is not offered in the prison. Other than if the one women's prison in Maryland does offer it, I don't know again why that is. So I think it's a great question. I think everybody should be offered treatments for their chronic medical illnesses.
Great. Well, thank you, Eric. I see we are actually just a little bit past time, so I am going to have to end the webinar there. Thank you, Eric, Dan, Gabby, Essence, for absolutely stellar presentations and discussion. And again, thank you to the audience. We have a lot of terrific questions, a lot of great interaction in the chat. We will, as you see, make the recording and the presentations available. We'll also make sure that the issue brief goes out with those follow-up items, and we will do our best to also try to work with our presenters here, answer a few more of the questions and get those up in an FAQ document for you in the coming weeks as well. Again, thank you, and look forward to continuing the discussion. There's a lot of terrific work here, and we hope to be part of building on it going forward. Have a good afternoon, everyone. Bye.
Yeah.
Thank you.
Thank you.